We're talking type 1 diabetes and type 2 diabetes, two different diseases. Type 1 diabetes is an autoimmune condition. It comes from the beta cells no longer being able to produce insulin in the pancreas. Type 2 diabetes often happens later in life, and this is a burned out pancreas, so much insulin being produced it just can't anymore, and an insensitivity in the peripheral tissues to the insulin itself. You're going to encounter diabetes constantly, on a daily basis, multiple patients a day. Usually, like 99 times out of 100, they're going to be your type 2 diabetics. And occasionally, you're going to get a type 1. Just know that they're treated a little bit differently. Don't get them confused and don't treat them the same way. When the patients come to you and they have diabetes, the type 2 diabetic, they're going to be a little older, overweight, and likely present with all kinds of other comorbidities, including hypertension, maybe even cardiovascular disease already, hyperlipidemia, and often a predisposition to type 2 diabetes, as this is often inherited genetically in the family. Your type 1 diabetic is going to be different. Okay, these are going to be younger, thin patients, and they're likely going to tell you that they were diagnosed at a young age with diabetes. There is such a thing as maturity onset diabetes of the young, or MODY, I think it is, and that's really rare. The type 2 diabetics are going to have a lot going on in their history, as I've already said. They're going to have a lot of comorbidities. That's because it's a chronic inflammatory state. They're going to have a lot of cardiovascular disease, maybe hypertension, hyperlipidemia, and if not, they still may be on the drugs. Why? Because there's trials and there's guidelines that a lot of these diabetics, you got to protect them from cardiovascular disease. So they may already be on a statin. They may already be on an ACE inhibitor because you got to protect the kidneys and you got to reduce the risk of heart attack. Type 1s, on the other hand, are simply going to tell you that they've had the disease their whole lives. When you're obtaining a history in the diabetic patient, it's important to ask a few key things. First of all, their last A1C and what it was if you don't have access to it. Type 1s, they're probably going to know it. Type 2s, less likely. They have their A1C checked so often and they're kind of new to the diabetic world. The Type 1 diabetics, they're going to know exactly what an A1C is, and they're likely going to be able to tell you what that number was. With the Type 2 diabetics, what you want to do is focus your history on some of the comorbidities that occur with diabetes. You're going to want to ask things like peripheral neuropathy, erectile dysfunction in men, or visual changes. A lot of times you're going to encounter these diabetic patients in the hospital already, and they're going to be either in DKA or HHS. The difference is that type 1 diabetics are usually the ones that go into DKA. The DKA is spawned by sometimes an infectious event or some other stressor. They've got no insulin in their body, their sugars go up, and they go into fatty acid metabolism. They produce a fatty acid called beta-hydroxybutyrate, which you can test for in the ER. Other things that will point to DKA besides of them being a type 1 diabetic is they'll be exhibiting Kussmaul breathing, which is deep, heavy breathing, and they'll have a metabolic acidosis or an anion gap when you calculate it out. Your type 2 diabetics are going to be a little bit different. They may not necessarily have metabolic acidosis. Their blood sugar levels are often quite higher than in a type 1 and DKA, maybe above 500. Your type 1 diabetic is also going to be exhibiting abdominal pain, nausea, vomiting, as well as the Kussmaul breathing in DKA. So when you have your type 1 diabetic or your type 2 diabetic in the ER in DKA or HHS, I think we treat them pretty similarly. We go through a DKA protocol. Your hospital is likely going to have one on hand. Know this, that potassium is going to shift extracellularly into the plasma. So although your patients may show a normal or even elevated potassium on their electrolytes, you're going to want to provide extra potassium when you start giving them fluids, insulin, and glucose if needed when you're getting them out of DKA or HHS. That's because as you start administering insulin, insulin is one of the things that will pump potassium back intracellularly and deplete it from the extracellular space, which can be dangerous. On physical exam, type 1 diabetics aren't going to have a lot to find except that they may be thin. Type 2 diabetics, you're always going to want to do a foot exam, make sure they don't have any ulcerations or trauma to their feet. As they have peripheral neuropathy, they could stub their toe and not even know it. Other things you're going to want to check on physical exam is acanthosis nigrans is often evident especially in younger patients who have a predisposition for type 2 diabetes. When performing a diabetic foot exam, you'll want to use a monofilament and check for the sensation to be intact appropriately in both feet. Labs for diabetics are going to be your basic classic labs, a CBC, a CMP. You're going to want to monitor kidney function because diabetes certainly has a propensity to cause chronic kidney disease. Furthermore, in your type 2 diabetics, when you're monitoring their use of metformin, there comes a time with a GFR, I think it's around 30 or below, you're going to want to pull back or discontinue the medication. Once a year, you're going to want to get microalbumin testing, diabetic patients to test for protein spillage in the kidneys. And you're also going to want to send them yearly for an eye exam. Also, the lab to order is the A1C. Every 3 months for an unstable diabetic, every 6 months for a stable diabetic. Now, diabetes is diagnosed by an A1C of 6.5 or above, or you can do some fancy glucose work like single glucose test above 200. That could be diagnostic of diabetes. Or if you get two fasting glucoses above 125, that's diagnostic. Or you can do a 2-hour glucose challenge, and if that's above 200, that's also diagnostic for diabetes. As I said, follow the lipids of the type 2 diabetics because they do have this propensity to develop cardiovascular disease, and you want them on the appropriate dose statin. And for your type 1 diabetics, I often see a TSH checked because one autoimmune often begets another. So check that thyroid. We already went over the diagnosis of diabetes. We left one thing out, and that's that pregnant patients need to be tested for gestational diabetes. You're going to test your pregnant patients twice for gestational diabetes, once on intake and another between the 24 to 30 week period of gestation. So for treatment of type 1 and type 2 diabetics, well, the type 1s are going to be easy because all you need is insulin. You need a long-acting insulin, and then you need a short-acting insulin for meals. And they'll often be dosed with a lower dose of insulin than your type 2 diabetics, and you'll check their sugars 4 times a day. Type 2 diabetic, the first drug you always choose is metformin, and then after that, there's this long list of all these different fancy medications that are very complicated and difficult to memorize. But the thing is that there's no one right answer for what you choose after the metformin. There is something that you can download on your phone. It's called the AACE guidelines. This is the Endocrinology Association, and they have an algorithm which you can follow, which shows all the different medications you can choose after metformin, the side effect profile for each, as well as some of the cardiovascular protective profiles of some of them, which can kind of guide you in your choice of what you want to use. Eventually, if those fail to keep the A1C low enough, you're going to have to just go ahead and resort to using insulin, often at a much higher dose than what your type 1 diabetics are going to be getting. A classic question is, how does metformin work? And just know that it prevents gluconeogenesis in the liver. And your pregnant patients, if they do end up having gestational diabetes, they'll be placed on insulin. When your type 2 diabetics are admitted into the hospital, they often take away the medications that they're on and just place them on insulin. There is some literature coming out now that supports the continuation of the outpatient oral diabetic medications, but that's likely only happening at certain hospitals and hasn't been a widespread acceptance yet. That's because metformin and the combination of metformin and IV contrast could be harmful to the kidneys. So when you admit a patient and you want to place them on insulin and you're trying to figure out what kind of dose, what you can do is you can take their weight in kilograms. And then based on their BMI, you can either multiply it by 40, 50, or 60%. The higher the percentage, the higher the BMI. Whatever number you get from that, you divide it into 2. Half of that's going to be the long-lasting insulin, and then the other half is going to be the prandial insulin. You'll divide that into 3. And then you can just add a low-dose sliding scale to that. And then throughout their hospital stay, you can monitor their sugars and adjust accordingly.